Good afternoon. Thank you for joining us. We're excited to share some of our work that we do in CICU. Amber and I are here to share this work, changing our paradigm, increasing assessment, and providing real-time feedback utilizing a web-based data collection tool to decrease our hospital-acquired conditions. So some background. Why is this work important? So as we know, hospital-acquired conditions are really preventable events or conditions that happen or that the patients acquire here in the hospital under our care. There are several data out there that's saying about 1.7 million people are affected each year with hospital-acquired infections like CLABSI, COTI, VAP, or CV, SSI, or surgical site infection. About these hospital-acquired infections also increases length of stay, about average of 18 days for the patients, and around 100,000 patients are reported to have died due to hospital-acquired infections. Particular about costs associated with hospital-acquired conditions, it's around 5 billion to 59 billion. Treatment for a UTI costs around $600. Prolonged BSI costs around $50,000. So the work that we do here really is important. And as we know, everybody knows, bundle compliance is the best practice to decrease hospital-acquired conditions. Our challenges is with getting this data. Doing bundle of compliance audits, as we all know, is very time-consuming. One audit is about a page long, and it's only for one condition. So for 8 conditions, like your CLABSI, COTI, CVSSI, pressure ulcer, peripheral IV infection, falls, injury from restraints, and unintended extubations, that's already 8 audits right there that we're asking our bedside nurses to do. And of course, who has time to do that, right? Well, some of our non-clinicians have time to do that, so they help us, our quality improvement people, to do that. But we're only able to do about 10 audits per month, which really is just a snapshot of what our care, provision of care in the bedside. Another thing is there's no real feedback that's being given to the clinical staff. The feedback happens way after the fact, and usually they don't hear about it. So their participation or the feedback that's needed to happen is not happening. So our solution is to create a nurse-driven, patient-focused, web-based data collection tool that will really increase our data collection sample size, be owned by the staff, by the CICU staff, patient-focused rather than hack-focused. And of course, increase staff awareness and have it available, have the tool available for them in a web-based data. So to meet our goals, we implemented this paradigm shift. We collated 8 bundle of care assessments or bundle of care compliance into one web-based data collection tool. And that 8 includes your CLABSI, COTI, CVSSI, pressure ulcer, peripheral IV infection, injury from falls and restraints, and unintended extubation. So to do this, we actually created a REDCap database, and it became our ICU care bundle of our ICU bundle of care assessment tool. We also educated all our nurses to the bundle, web-based, how to answer each question, and the data interpretation. So we're now providing real-time feedback about this bundle of compliance. What's really exciting also about this is now that 8 bundle of care is in one survey assessment, it's now a comprehensive assessment of the care that we provide to the patient. So it's really patient-focused. It's not just focused on one hospital-acquired condition, as the traditional paradigm is. We identified a champion for each hack element, for each hack, and they serve as the bedside content experts. And we made the tool readily accessible. It's in all the CICU computers as an icon. And now our bedside nurses are the ones doing the data entry rather than a non-clinician or the nurse leaders.
So what did this mean for nursing practice? So when someone else comes into your unit to do your data analysis, they come in for 5 minutes, they run through the unit, they collect data. It's a very inefficient sample size. So they were only able to collect about 10 audits a month on each individual thing. When we took over our data analysis, we were able to increase our sample size to 50 audits a month, which is 150 per quarter, which is a whole lot better than they were doing coming in from the outside. And then we put the web-based data collection tools, so we didn't have to do a lot for the data collection. It was already, it's an icon on the computer, they click on it. It is, what's it called?
ICU bundle of care.
No, the
Record?
Sorry. Conditional logic.
Conditional logic.
There we go. So the questions pop up. If I have a central line, then I get more questions to answer. So if you have a really easy patient, you don't have to answer many questions, so they don't have to scroll through pages of information. So it was much easier for them to use. And then we also, when you go in to answer the REDCap database, you're actually looking at what the nurse before you did. So you go back in the chart, see if they were compliant on their bundle, which also serves as a reminder for you to do your own. So you, oh, they didn't do their mouth care, I better do it so that the next shift doesn't seeing that, like, caught that I wasn't compliant for my bundle. So they got real-time feedback. There was real-time feedback. If the nurse left and they forgot to do something, they come back tonight, you're like, hey, you forgot to document that your central line dressing was clean, dry, and intact. So it was a peer-to-peer involvement rather than Annie and I walking out on the unit going, hey, guess what you didn't do? So much better received from peer-to-peer and educational at the same time. And then along with this, we were able to show over our first year of involvement that we actually decreased our hack incidence. So there was a correlation with education and bundle compliance that increased the incidence. So what you'll see on the graph are one for our urinary catheter Foley compliance, and then on the other side is the skincare compliance. So, and it's per quarter, so FY14 quarter 2 was when we implemented our education. So we began nursing education on what the bundles were, what the data collection process was, and then you slowly see so the line graph on top of the bar graph is the number of patients assessed with each condition. So you see as that number goes up, we were rocking it hard in quarter 4 of FY14. That was our initial turn it over to the bedside nurse and everybody was on board. We've slowly since declined, but eventually hope to increase those numbers back up. So this was our increase in data collection. So as you see, the quarter 4 was great. We collected 400 data points for the 3-month period. We actually have a potential of collecting about 1,400 data points a month. So we're still below where we want to be, but future endeavors in progress. So this is a chart showing our incidence of hacks. So on the top, you'll see CLABSIs and CAUTIs and SSIs. So in an 18-month period, we've had 2 CAUTIs, 2 CLABSIs, and 7 SSIs. So I think our initiative is gone kind of interdisciplinary. So as you see on the SSI one from August of last year, we haven't had a surgical site infection. I didn't really know why, and I ran into Chona, who is the CV surgery OR nurse, And I was like, Shona, I don't really want to tell anybody, but for like 8 months, we don't have a surgical site infection. And people are actually contacting us about what are we doing. So she jumped on board and said, you know, where I used to work, the CV surgeons were changing their gloves when they closed the chest of the patients. They weren't using their dirty, bloody gloves. They were actually taking them off, putting on new clean ones, using an antibiotic scrub, then putting on the chest dressing. She's like, I just implemented the process. I'm like, great, Shona. Let's not tell anybody. Let's wait till we hit a year with no SSI. But everybody else is getting on board. So it's filtering out through the institution, but still don't tell anybody outside this room. So our current goals, we created the learning tool for the bedside nurse. They're able to evaluate the patient and do an evaluation of themselves at the same time. We were able to increase our data collection process and show a correlation with our decreased incidence of HAC. Where we are headed in the future. So the dashboards that you saw earlier from Krista Cato's and Dr. Fetterman's report, we hope to make, so currently the dashboards show if the head of bed is up, if there was mouth care done, but those are individual pieces of bundle compliance. We hope that in the future our dashboard will show central line compliance, and it will just say central line at the top and have an X or a check mark, and then you can hover over it to say what parts of the bundle weren't done so that the nurse can go back in and do those pieces. So it doesn't matter if I put the head of the bed up to decrease your ventilator-associated pneumonia if I didn't do mouth care. You need all of the bundle elements in order to be compliant and decrease your HAC incidence. Oh,
I think we'll save questions later.
Okay. Do I have any questions?
Thank you.